Hi, everybody. The question I want to address today is prescribing opiates with benzodiazepines or sedatives. For those of you that are new to the channel, my name is Dr. B. This is Dr. B Addiction Recovery. On this channel, we cover all things substance abuse. If you appreciate the content, please go ahead and subscribe and press the like button. If you are so inclined, we have a Patreon account for as little as $3 a month. You can contribute to our efforts of education. Let's get started. The question is regarding, can you prescribe opiates and benzos at the same time? And I think this is a great question, and it's a controversial question. And I'm going to approach it a little bit in a historical manner and move up to the environment of standard practices today for this kind of thing. And from there, I'm going to move on to buprenorphine, Suboxone, maintenance treatment issues, and prescribing benzodiazepines. And hopefully I can clear up some misunderstandings in this area. So in general, as we know, a lot of the opiate overdose deaths are polysubstances, and in that sort of mix is a lot of benzodiazepines. And we know really clearly that the combination of opiates and benzodiazepines can cause a fatal overdose, and they work synergistically in decreasing respiratory center drive. And respiratory depression, you stop breathing. This we know from accidental overdoses from recreational drug use. Okay, and now and this has been a big topic, and it has really become the forefront of this discussion and our sort of substance abuse epidemic across the country. Now, given this issue over the last few years, we've seen major practice changes with clinicians and physicians, pain management, primary care, and addiction doctors. And one of the things that has happened, especially with pain management, people have become extremely cognizant of when and if they're even prescribing opiate medications and adding a benzodiazepine to that mix. It's probably, for the most part, not really done, and really looked down upon if it is done. And to a great extent, that makes a lot of sense. If you're giving someone a full agonist opiate, even if it's prescribed, and if you add benzodiazepines, and if there's any potential for abuse, this should really be approached cautiously. If you notice, I don't say it should never be done. And in my personal practice, there's really no patient that is on a full opiate agonist. In fact, there's very few patients on a full opiate agonist and a benzodiazepine. If I was a pain doctor, I would probably have a lot more experience with this, but I think most of them would say that there's been a change in practice patterns, that if somebody is on a full opiate agonist like oxycodone, it is very unlikely they're going to be on a benzodiazepine. Interestingly, I do think they are still prescribing gabapentin, which in some ways has just as sedating effects, can have just as much sedating effects as benzodiazepines, and a person might be opiates. But now we start to go into permutations and derivations of this issue that we can address somewhere else. There's some concern here without even getting into the buprenorphine issue, and it's this. I think most of us clinicians nowadays really, like in every other sector and area in our society, have a knee-jerk reaction to recommendations and societal reactions. What do I mean by that? As a clinician, one of the things, as a professional, one of the things you are supposed to do is have enough education, enough clinical experience, enough ethics, and your judgment should be really fine-tuned to decide a certain case and make that decision. And probably, I can say safely, it's not illegal to prescribe opiates and benzodiazepines, but it's unlikely that there's too many people out there prescribing full agonist opiates and benzodiazepines. And in this case, there's a good cause. The two of them are a deadly mix, as I've described in another video. But I want to present an example. What if someone has something as vague as low back pain, and they are on very low dose of Norco once or twice a day, and maybe 5, 7.5, whatever it is, and they've been on this for, let's say, 15 years, and they have also been from anxiety or panic disorder or whatever event it is. They're also on 2.5 milligrams of Valium for that same amount of time. What you see is that a case where it would be silly or foolish to continue that prescription pattern? I don't know. I'm hoping I generate discussion out there, both amongst the patients and maybe some professionals that are in this situation. I can see that in general, when I deal with a lot of the pharmacies, unfortunately, a lot of them have stopped thinking and practicing their professional judgment and working with the physician. Now, this might be to a great extent because they're working for these big corporate chains and everyone needs to make a living. And I do understand that to some extent, but it appears that professional judgment has to a great extent gone out the window, at least in this area. Let me move on to an area that is really, for me, on the border of silly, if not much more obvious. That's what the answer is. That would be the right way to say it. Practicing addiction medicine, as I do, and prescribing lots and lots and lots of buprenorphine products, oftentimes Suboxone. And the data does show very clearly that mixing opiates with benzodiazepines is a cause for increased potential of overdose with decreased respiratory drive. Now, when you're dealing with Suboxone, you're actually dealing with what's called an agonist-antagonist opiate, okay? And so, in theory, it is supposed to be, or there's a ceiling effect on the decreased respiratory drive, okay? That's in theory, and for the most part, that is what you see in practice. For example, you don't really see clinically decreased respiratory drive going from 18 milligrams of Suboxone to 24 milligrams. Yet I hear over and over and over again from patients, changes such as this induce the physician to say, I'm not giving you your 10 benzos a month because you're going to have decreased respiratory drive, and a complete misunderstanding of what the data shows. Now, I will admit this. The data does show that there is some increase in chance of decreased respiratory drive when you are on Suboxone and mixing it with benzo. And that data is a little bit controversial, and I'm going to get to that. But let's get to the clinical side of this. Let's take someone that many addicts in general have major issues of anxiety and panic disorders that need to be treated. And in fact, many of them do have a history of misuse or abuse of benzodiazepines. But as a clinician, as you negotiate that addict, and let's say you have them on maintenance medication of Suboxone, let's say, whatever dose it's at, 16 milligrams, 24 milligrams, 12 milligrams, even 32 milligrams, every once in a while, you do get in a situation where a benzodiazepine is needed. And sometimes it's even at what seems like a higher dose. 2 milligrams of Klonopin twice a day is a pretty big dose, actually. But you also have to take into consideration knowing the fact, well, let's begin this way. Knowing the fact that mixing these two in general, opiates and benzodiazepines, decreases respiratory drive and increases chance of overdose death. Now you're dealing with an agonist-antagonist opiate, which doesn't have the same effect, not nearly as much as an agonist opiate like oxycodone and heroin. And you might be dealing with a situation where a person has a high tolerance for benzodiazepines. Either it's from real anxiety or misuse and abuse, and you want to do a slow, long-term taper. And you should have enough autonomy and judgment, understanding of these medications to make that decision and call to go ahead and prescribe that if you're comfortable. And what do I mean by comfortable? Knowing your patient and doing it in a way that creates comfort. So let me give you one example. Let's say you get to a decision where you're like, well, this guy absolutely needs benzos. And in the spirit of harm reduction, if I don't give him the benzos, he's going to misuse and abuse on the street and maybe not even start his buprenorphine. And let's just say you're just getting to know this guy, and the expression is that he's expressing to you that he really wants to get clean. And so you also know that he has quite a high tolerance. And let's just, for example, say you're going to decide that probably if you were going to give it 2 milligrams of Klonopin twice a day, which is equivalent to about 8 milligrams of Xanax, twice a day would be appropriate for this patient at this time, in addition to the 24 milligrams of Suboxone. Can you do this? This might generate a lot of controversy and discussions below from patients and professionals alike. And I'm going to argue that you can absolutely do this, and you should do this, because if you don't, you are actually potentially causing more harm for the patient, and you're reacting to a societal position, whereas before everything was okay and everyone's getting everything. Now, because there's been such a swing of the pendulum, you're not making your own decision that this patient needs this amount. But there's also safety mechanisms you can put in the way you prescribe this. Number one, you're not going to cause an overdose to somebody that's tolerant to this high doses of medication, and they're high and they're not high for others. Especially with Suboxone and its ceiling effects. Okay. Number two, there's ways to do this to give yourself clinical safety until you build rapport with the patient and know who this patient is. For example, you see the patient on a Wednesday, and it might be your first time seeing him, but usually it takes a few times before such decisions are made, and you want to test the waters. You don't have to give them 60 tablets of Klonopin for a month to give them 60 to 90 8 milligram strips of Suboxone and send them out there and say, manage this on your own and see you in a month. You can give 3 days, 5 days, 6 days of these medications until you feel comfortable. And if the patient rebels against this idea, the answer is very easy. The answer is, well, look, most guys wouldn't even prescribe you this regimen of medication. I actually think in the long term, the benefit is much greater than the risk in keeping you clean and tapering down the benzodiazepines. You spent the last 5, 10, 15, 20 years abusing drugs, and now you're telling me if I give you only 3 days or 5 days or 7 days worth of medication, you're going to protest because it's uncomfortable or a discomfort or a nuisance for you to come back in until we build a rapport and I do some clinical engagement to make sure you're on the right track. If that's your position as a patient, then I probably shouldn't be prescribing this medication in this way to you. In addition, you have the power of a report in California. It's called the Cures Report, where you can kind of monitor any other prescriptions they get that are scheduled and from other practitioners. In addition, depending on how you, the practitioner, want to use it, you have the power of urine toxicology, whether it's point of care or sent to the lab. And finally, you have your clinical engagement, where you can make judgment and decisions regarding if they're calling you early, if they look like they are using, and things will add up. And so there's a lot of ways to approach this, but the point that I'm trying to make here is the idea that buprenorphine products, given the fact that they're agonists, antagonists in nature versus full agonists, such as heroin or oxycodone, have the same increased liability when mixed with benzodiazepines is ludicrous. And the fact that as a clinician, you're going to pull the trigger and make a sweeping judgment on a practice pattern, well, this is the same way we've always practiced, and this is what gets us in trouble, and patients are not taken care of. On the clinician's part, I encourage one to have the courage of their convictions and their education. I'm going to get to one more issue here and just clarify something to add to my argument, and that is, does buprenorphine actually decrease respiratory drive like full agonist opiates? And to the best that I can gather, it's this. If you go to European countries, in particular France, they're very used to giving high doses of buprenorphine. Okay? And across Europe, I think there's at least 100 overdoses associated with buprenorphine products, right? And most of those are marked as asphyxiation, choking. And the other one is they're also associated with concomitant use of a psychotropic, often a benzodiazepine. Here's a couple of things to note on that and to catch about that. Number one, we're talking about high doses of buprenorphine products. Number two, we're seeing this with misuse of buprenorphine products through injection of the buprenorphine products. Number three, one of the breakdown products of buprenorphine, norbuprenorphine, is really the culprit attacking the respiratory centers, and the mechanism is actually not known. And there's one more thing that should be noted here that's really important to ward off against abuse of buprenorphine in those ways. High dose overdose of buprenorphine, when it affects the respiratory centers, is resistant to reversal through naloxone. I don't know if many people know that, but it's important to know. So what am I saying here? I am saying good clinical hygiene and practices sort of mandate for you to understand the mechanism of these medications and the risk of overdose, especially when you're adding something like a sedative, a benzodiazepine, and you can do it safely, and there is a select number of patients that need it, and it would serve them well if you made that judgment and prescribed it if you're comfortable, so that they can stay clean and sober and give them the quality of life at that time, and consider tapering the sedative if appropriate. Number two, I'm not denying that a certain dose of buprenorphine at certain high doses absolutely affects respiratory centers. But I gave some literature examples of that, and I even said there's over 100 overdoses documented across Europe. Most of these are at super high doses, which is a reflection of the French giving high doses of buprenorphine, Suboxone products. Most of these are misuse and abuse, injection, and concomitant use of other psychotropics, some of them benzodiazepines. So the danger is there, and I'm not advocating for anyone to not take this seriously, but I am also at the same time saying for the clinician, the judgment should be used to add benzodiazepine, if necessary, to the buprenorphine product for a substance abuse client, and we should not make across-the-board judgments and decisions that are all or nothing. I hope this video helped your understanding of this situation. I hope it generates some controversy. You don't have to agree with me. In the comments below, give your feedback. I welcome all of them. If you enjoyed it and thought it was useful, please click the subscribe and like button. And there's other videos like it. Click the link above to my left. Have a great day.